Hello everyone, Anthony here from Succeeding in Nursing School, and today we're going to be discussing diabetes, specifically type 1 and type 2 diabetes. While there are other types of diabetes, including gestational diabetes, diabetes insipidus, and medication-induced diabetes, these will not be discussed in this video. The topics I will cover today include the differences between type 1 and type 2, including general population and age groups, signs and symptoms for each type, complications of each type, and treatment modalities for each. To begin, we will discuss type 1 diabetes. Type 1 diabetes, previously known as juvenile diabetes, as it occurs mainly in children and adolescents, is a condition where the beta islet cells of the pancreas have been destroyed. This can either be a self-immune mediated destruction of the beta cells, or it can be secondary as a result of a virus or injury to the pancreas. With no beta islet cells functioning, there is no insulin being released, causing a cellular deprivation of glucose as it cannot be transported to the cells. Since glucose cannot be transported to cells, it accumulates in the bloodstream, causing hyperglycemia. Along with this elevated blood glucose level, the body is now forced to produce ketones for energy since it is unable to use glucose for its metabolic needs. This leads to a state in the body where we have an elevated glucose, ketones present, and due to the presence of ketones, which are acidotic in nature, we create an acidotic environment in the body, which gives rise to a condition known as diabetic ketoacidosis, or better known as DKA. The characteristic sign of DKA is a fruity smell in the person's breath due to the accumulation of acetone in the mouth, which is a byproduct of ketone production. Patients in DKA will generally have a blood sugar above 600 milligrams per deciliter, a pH between 7.25 and 7.35, although it can be lower depending on the severity, and they will be dehydrated with electrolyte abnormalities, mainly hypokalemia. When acidosis occurs within the body, hydrogen ions in the blood force potassium into extracellular space so the cells can uptake the hydrogen ions in an attempt to maintain a lower pH and aid in the excretion of them. This causes a transient rise in potassium, as most potassium is generally stored within the cells. Approximately 99% of the body's potassium is stored in the intracellular space. So if your patient in DKA has a potassium of 3.6, while that is in the normal range, since they have an acidotic environment in their body, their true level is actually going to be quite lower, and they more than likely will need supplemental potassium to prevent hypokalemia from developing. Eventually, if left untreated, the combination of cellular starvation, acidosis, and development of hypokalemia will be fatal to the patient. Causes of DKA are generally a result of missed medication doses or underdosing of insulin. But other causes include extreme periods of stress, either from work, life, or any other cause that may contribute to increased levels of stress, illness, and starvation can also cause it. Treatment of DKA focuses on lowering blood sugar through the use of an insulin drip and reintroducing fluids to correct dehydration. Depending on the facility, there will be a guideline of when to switch from a 0.9 normal saline solution to a D5 solution with an insulin drip, but generally when the patient's blood sugar approaches around 250 milligrams per deciliter, the bag should be switched to prevent hypoglycemia from occurring. Prevention of DKA revolves around ensuring the patient is well educated about properly using their insulin. Type 1 diabetics are completely reliant on exogenous sources of insulin, so their knowledge of proper dosing amounts, timing of dosages, and sick day rules are vital to their health and well-being. The other type of diabetes we'll be discussing is type 2 diabetes. Type 2 diabetes is more complex and is a result of one of three things: decreased secretion of insulin from the beta islet cells, decreased sensitivity within the body to insulin, or destruction of beta islet cells, which can result in transition from non-insulin dependent type 2 diabetes to insulin dependent type 2 diabetes, or even a transition from type 2 diabetes to type 1 diabetes. While type 2 diabetes does have some genetic predisposition, the most common causes are lifestyle choices, including a poor diet, lack of physical activity, and obesity. With type 2 diabetes, the body is still able to utilize insulin to some degree, but not enough to manage the glucose intake associated with most diets. Because the body can still utilize some glucose, there's a lack of ketone production, so DKA and type 2 diabetics is rare, except in severe cases. Blood glucose levels rise slowly over time and eventually reach over 1,000 milligrams per deciliter if left unmanaged, and this creates a condition known as hyperosmolar hyperglycemic nonketotic syndrome, otherwise known as HHNKS or simply HHS. Patients with HHNKS are much more dehydrated than their DKA counterparts due to the hyperosmolar state, causing excessive levels of glucose as a result of excessive levels of glucose, causing excessive urination. HHNKS can be fatal due to the electrolyte imbalances that occur along with dehydration, with the most significant electrolyte imbalances occurring being hyponatremia and hypokalemia. Because of this, fluid and electrolyte replacement actually takes priority in treatment of these patients, with blood sugar management being the next highest priority. Generally, patients in HHNKS have lost at least 9 liters of fluid, or 3 gallons, so fluid replacement is essential. Fluid replacement choice is dependent on electrolyte levels. Supplemental potassium will almost always be given due to the high rate of hypokalemia, and it can be anywhere from a 20 milliequivalent to a 40 milliequivalent bag given, as much as needed. And depending on the patient's sodium level, either a 0.45 or a 0.9% saline solution will be used for fluid resuscitation. Fluid volume replacement needs to be done cautiously, however, especially in the elderly patients or those who have any kind of cerebral trauma, as if you cause a fluid volume overload, you will create new problems associated with it, and you can also exacerbate hyponatremia, depending on the solution used. As with patients in DKA, when blood sugar levels return to around 250 milligrams per deciliter, the fluid should be switched to a D5 to prevent hypoglycemia from occurring. Diabetes as a whole is associated with development of numerous medical abnormalities, including cardiovascular and metabolic disorders. While the mechanisms are not completely known for causing cardiovascular issues, prolonged exposure to elevated glucose levels over long periods of time is thought to be the driving factor. Some of these conditions include atherosclerosis, myocardial infarction, stroke, and one of the most common being diabetic neuropathy or nerve pain. Metabolic disorders result from both diabetes and the lifestyle choices associated with most people who develop diabetes, which include obesity and a sedentary lifestyle. Excuse me. These disorders include hypercholesterolemia, insulin resistance, decreased metabolic rate, hypertension, increased waist circumference, and elevated blood sugar levels. Metabolic syndrome is associated with most of the adverse effects related to diabetes, and preventing it could be the cornerstone to reducing diabetes-associated mortality, not only in the US, but also around the world. We've talked a lot about diabetes itself, but before I end the video, I want to touch on the most clinically significant aspects of diabetes, being hyper and hypoglycemia. Hyperglycemia is characterized by a fasting blood sugar reading above 140 milligrams per deciliter or a random blood sugar reading above 200 milligrams per deciliter, while hypoglycemia is defined as any blood sugar reading below 70 milligrams per deciliter. Signs of hyperglycemia include polydipsia, or increased thirst, polyphagia, or increased hunger, and polyuria, or increased urination, as well as weight loss, fatigue, blurred vision, and blood sugar reading over at least 180 milligrams per deciliter on a random test. The signs and symptoms of hypoglycemia include being cool to touch, diaphoresis, decreased mentation, excessive hunger, seizures, and fainting. If someone becomes hypoglycemic and they are awake, they should be given 4 to 8 ounces of a sugary juice, followed by some form of a slower digesting carb and protein, such as peanut butter and crackers, or a ham or turkey sandwich. Their blood sugar should be monitored every 15 minutes until they are within the normal range. If the person is not awake and they are hypoglycemic, treatment depends on location. Outside of a hospital setting, the patient or the nursing facility should have glucagon available and should be administered as quickly as possible, and the patient should be taken to the hospital via ambulance. Within the hospital setting, 1 amp of D50 will be given through an IV line every 15 minutes until blood sugar is within normal range, and the blood sugar will be checked about every 15 minutes. If the patient is hyperglycemic, depending on what type they are, most of the time if they're in the hospital though, they will be receiving insulin. Otherwise, you will just have them take their normal diabetic medication. For now, this is going to be all I will talk about with diabetes, at least type 1 and type 2. So leave a like if you enjoyed the video, subscribe, and in the comment section, leave any type of video discussion you would like being done. Thank you and have a good one.